Hey everyone, it's Nancy, the nurse practitioner here. Today we are going to talk about high cholesterol. Boy, do we know a lot about cholesterol. We hear it all the time on the news. We hear it all the time when we go for a physical or to our clinician. And as we get older, our cholesterol does go up. So get yourself something nice, like a cup of coffee or your favorite beverage, and we're going to do some PowerPoint together. And I'm going to show you some things about high cholesterol, what you can do about it. Okay, so I'm going to share my screen with you, and we're going to talk about high cholesterol and atherosclerosis, what you need to know. So we're just going to keep going on here, and we're going to talk about what is cholesterol, what is atherosclerosis, how do we determine our cardiac risk score, which will help us determine, what we need to do. It's almost like a crystal ball for our future for heart disease, how you can reduce your cholesterol, drug therapy options out there if we have to go that route, and other testing to determine your medication needs. So here we go. Let's first talk about cholesterol. What's in cholesterol? I know there was a lot of this alphabet soup here. We're going to just run through some of these. And if you look at your blood work that you get back from your clinician's office, they all have these levels on them: LDL, HDL, VLDL, and your total cholesterol, which is TC. But let's go through what these components are. And back in like early 2000, when I was doing cholesterol screenings, I was doing something called an NMR, which is a fractionation test to determine if your LDLs were good LDLs or bad ones, and HDLs, good ones or bad ones. So it's interesting, it's more complicated than we thought. And it did help me determine whether people at that time were able to get by without medication, even if their numbers were high, the cholesterol numbers were high. And, you have to look at the whole picture, their family history, their previous genetics, their own history, their lifestyle, and other things. So we're going to go over all of that together. But let's first talk about LDL, which is a low density lipoprotein, or the bad cholesterol, they called it. This causes something called oxidation or rusting. Think about a pipe in your kitchen, under your kitchen sink with rust in it. Oxidation happens as we age, and it can be reversed or reduced if we use certain ways of reducing our LDL. HDL, or high density lipoprotein, is a good cholesterol. It removes the LDL out of the blood to the liver, and it converts it to bile, and then it's excreted into the stool, and there it comes out. The VLDL is the very low density lipoproteins. It's considered a bad cholesterol, but it mainly carries triglycerides, the most common type of fat in your body. And they're bad news, actually. Then there's these two proteins that I thought you should know about, because I have had this test done when I go for my blood work, just to see if I have ApoA is more than the ApoB. ApoA1 is a protein produced in the liver and in the intestine, and it's found in HDL, or high density lipoproteins. Its role is to help that HDL to remove the excess peripheral cholesterol, return it to the liver to recycle it and excrete it. So that's a good guy. ApoB is a protein found in your lipoprotein particles that are artery clogging. So those are not good guys. When I think of B, I call them bullets. And I used to say that to my patients. They contain LDL, VLDL, and something called chylomicrons, which consist of triglycerides, cholesterol, and proteins. What is atherosclerosis? And atherosclerosis is a chronic inflammatory process. It takes a while for this to happen in our bodies, but years and years of things happening that are not good leads to this condition. It targets the large arteries. It starts in our childhood. It involves our genetics, and environment plays a major role. Every year I sit around the table whenever we don't have COVID around and talk to my family members about what happened to them this year. And I have 7 brothers and sisters. So are you guys okay? What's happened? Are you on cholesterol medicine? Have you had any events, any problems? It's just something that helps us determine what our genetics are going to tell us. And that's really important to know, because sometimes we know what's coming just from our genetics. So let's look at some calculations you can do on your own. You could take your total cholesterol, your TC, and it's actually the VLDL minus the HDL plus the LDL. So you could do a little math and see what your total cholesterol and why they come up with the numbers when you look at your labs. Always ask for copies of your blood work too, and take it home, print it from your med site or your clinical site there so that you can actually compare on your own and keep record. It's good to be proactive, right? So taking the ratio of your total cholesterol to your HDL and the LDL ratio to the HDL, these can help us determine your predictors for coronary artery or heart disease. The lower the ratio value, the better the predicted outcome. So that means if your total cholesterol is 160 and your HDL is high, like 70, you're going to have a lower ratio, which means you have a better predicted outcome. Does that make sense? Okay. So let's get a visual here of what atherosclerosis looks like. This is a normal tube or artery that runs through our entire bodies. Many of them, they feed all our organs, our heart, our brain, everything. And a normal artery is nice and clear and open. And you can see the lumen, wide open, lots of flow, anything can go through there, looks great. And this cross section is showing where plaque starts to build up. When cholesterol, bad cholesterol just starts to accumulate and doesn't get removed and excreted, it builds up. And some arteries more than others. And then you get this lumen or opening, as you can see, that's very small, causes more pressure and difficulty for flow of blood through those arteries. So let's just go over some statistics about atherosclerosis and high cholesterol. Well, it's a leading cause of death in the developing countries, and we are a developing country. We eat a lot of fast foods, lots of stuff out of boxes, lots of breads, low grains, fats. You got it. You know what you're eating. And we are what we eat, by the way. In the US, 25.7% in America will die from coronary artery disease, and 47% in Europe. Pretty cool or interesting to have those statistics. I wouldn't think there was that high in Europe. And by the year 2030, there will be 23 million deaths worldwide from this condition. That's a lot of people dying from heart disease. And what's the burden on our medical society and all of us from coronary artery or heart disease? The cost of care for society is incredible, but we know that anything with early detection and intervention can help prevent a lot of problems in the long run. And that's the idea of getting early detection for anything. And why you should have a physical, why you should follow up on tests that were done. It's just taking care of yourself, just like you would your house. All the things that you keep doing, changing filters and getting your air conditioning checked and et cetera. So it's the same thing. So when you look at coronary artery disease or cardiovascular pathology, the things that we all know we have: high blood pressure, high cholesterol, diabetes, being overweight with a BMI over 30, which is obesity, smoking, physical inactivity, and poor diet. All these things we know, we hear it all the time, blah, 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 but it's truly the problem out there. And it takes a whole team to fix one individual: the clinician, the nurse, the dietitian, the pharmacist, the counselor, and the person. And so here are some other factors that can increase cholesterol, and these are secondary. Like if you have thyroid disease and it's not controlled, it can increase your total cholesterol. Obesity increases triglycerides and lowers your HDL. And we want that HDL to be high because HDL is a good guy. It helps us. As far as diabetes, it increases triglycerides and our cholesterol. Alcohol abuse increases triglyceride and high HDL. And HDL goes up, but it's not always the good HDL. And sometimes HDL gets to be about 100, and that's not good to have a level that high. If you have chronic renal problems, it increases triglycerides and total cholesterol as well. So how do we manage high cholesterol? Well, the U.S. Preventive Services Task Force recommends that adults without history of coronary vascular disease use a low to moderate dose statin for prevention of CV events and mortality when the following criteria are met. So you have to have these criteria that if you are adults without history of CVD using a low to moderate dose of statins. If you're over 40 to 75 years of age, you have one or more risks of heart disease, and you have a calculated 10-year risk of CV event of 10% or greater. And we're going to go over how you can calculate that in a second. So the American College of Cardiology, if you go online, you can actually do this yourself. I'm trying to make this a little smaller so you can see the whole screen. But these are the components that they want to know to determine your risk. How old are you? Are you a male or female? What is your race? What is your blood pressure, your top number and your bottom number? And you can see what it's asking here. Is your age between 20 and 79? Okay. Is your systolic blood pressure between 90 and 200? Must be between that. The value has to be between 60 and 130 for diastolic. Total cholesterol between 130 and 320. HDL between 20 and 100. LDL between 30 and 300. Do you have a history of diabetes? Are you a smoker? Were you a former smoker? Did you never smoke? And then you can calculate your percentage and tells you your 10-year risk score. And that will really determine how much are you in trouble from actually getting a heart attack. So let's talk about some things besides getting that tools that you can use. Now we hear about lifestyle modification all the time. Fruits and vegetables, whole grains, low fat dairy, poultry, fish, low amounts of red meat, low in tropical oils, reduced trans fats, lots of liquids. And liquids means water and juices that have less sugar in them. You know, I add a tea bag with lemon and lime in it in my water every day, and I sip on that all day, and it's great, tasty. Omega-3 fish oil, a lot of us are taking that, and it's found in fatty fish, which are salmon, mackerel, sardines, trout, herring, walnuts, canola, flaxseed, linseed oils, good stuff. And the Mediterranean diet, we all know, includes olive oil and a moderate amount of wine consumption, especially red wine. And adherence to the Mediterranean diet can reduce your LDL by 10 to 15%. That's an awful lot just by changing your diet. Okay, and we have heard that. So let's talk about drug therapy. You know, it should be not the first way to go. It should be the last way to go. And you need to wait till you are at high risk, or at least knowing that you have this score that shows that you're at high risk. So, you know, Crestor does do a great job of lowering cholesterol at a low dose, but you do want to make sure that you don't just jump on something like that if you don't have to. And they do have side effects, statins. 1 to 2% of the population has an elevated LFT, which is the AST or ALT, from statins, because everything is processed through the liver, you know, our big detoxifier, including drugs and everything else. So some people do have trouble. The complaints of some people is muscle aches, 10 to 15%. They just feel their muscles do not feel good. And they also can have a test called a creatine kinase, which is an enzyme found in the heart, brain, and skeletal muscle. And when it goes up, and it needs to be 10 times higher than normal, it shows that there has been muscle damage, and it's recommended that you stop the statin. And there also are some drugs you cannot take when you're on statins: amiodarone, erythromycin, protease inhibitors, which is used for HIV, grapefruit, and antifungals. You will need a fasting blood test first 12 weeks after starting a statin, and every 3 to 12 months to check your, you know, adherence and if everything's looking better. And moving on, there are other drugs out there besides statins: the bile acid sequestrants, niacin, which helps for very high triglycerides, but does cause flushing. You know, you feel hot. Sometimes an aspirin's added on to help you, and it's taken usually at night. fibrates, which also helps lower high triglycerides, fish oil. It reduces triglycerides almost 20 to 50%, but it does have an antiplatelet effect, which means then you got to watch out about the Plavixes and things like that you're on for other reasons. So who should be treated with drug therapy? You know, according to the American Heart Association, those with clinical aortic sclerosis or CVD, they have to have severe hypercholesterolemia, and that means an LDL over 190. That's first recommendation. Or people who are 40 to 75 years old with diabetes and an LDL of 70 or greater. Or people who are 40 to 75 years old with no diabetes, but their LDL is greater than 70 or equal to it and has a risk score that is greater than 7.5%. Okay, so we did talk about that risk score. It's really important to look at that and know if you are at risk. Now, the other thing to really mention is that after you hit 75, you may not need to be on a statin any longer. I found that many of my patients, as they got older and older, and if their lifestyle had changed and they were not that healthy, it was, why would they stay on a statin if they had pains and it didn't really help them? So talk with your clinician, review your medical history, and consider whether you're still at risk or whether you need to stay on that statin after 75. We talked about women for a few minutes about premature menopause. They may develop high cholesterol. And this is a very important fact. Homocysteine is an amino acid that increases and when it is increased, is correlated to brain atrophy in healthy older adults. Something really interesting happened to me is that I had an elevated homocysteine level for years. I did a special gene SNP test that determined that I had a problem with my Bs. I did not methylate or activate my B complex, which is B6, B12, B1. And I found out, and many of my patients, when I did a homocysteine level on them, I put them on something called Menentex, which is a prescription, but you can also take L-methylfolate, which you can get on Amazon, and my homocysteine level came way down. Very, very interesting that sometimes you genetically do not methylate your Bs. If you want more information about that genetic testing that I did, a gene SNP, you can email me at nancythenp@gmail.com and I will give you more information about that. Nancy, the NP for nurse practitioner @gmail.com. Okay, very, very cool test, and it works really, really well, and you really do find out whether it's something that would help you. Now, this is the jewel that I found through all my research, and I will tell you something. The Mayo Clinic has some wonderful, wonderful programs and information, which is where I extrapolate much of my information, but also from many other sites. But I love it because it's well written, easy to understand, lots of good visuals, and it's a really great place to go. So my doctor, or my cardiologist, actually, she's female like me, said, I want to increase your Crestor. I want to get your LDL below 70. And I'm like, okay, why? I'm not overweight. I don't smoke. I don't have diabetes. I have relatives that did have heart disease, but not till after they were 70. One had a stroke. My grandmother died of a stroke at 91. Only one of my brothers is on any cholesterol medicine similar to me, and I'm on Crestor 10. Not that I love being on it, but I'm on it. And so since I was seeing my total cholesterol really going high, changing my diet didn't seem to help. And I did hit menopause many years ago, 13 years ago. I was definitely running into some trouble. So I asked for a calcium score test, and this is what I had done. It's called a CT, coronary artery calcium scoring without contrast. And I actually was sent for this test. And these are the different arteries that were measured. The calcium score ranges from 0 to 1,000. So let's go over this. This is a very, very cool thing. When I'll talk you through the process and the whole situation, but these are the main arteries that were actually looked at through his CAT scan to see what kind of plaquing and calcification I had deposited in them and to determine whether or not I needed to really increase that crestor or not. So we're going to go over a few things here. This is about the heart scan. You know, a heart scan is a coronary calcium scan. It's an X-ray test. It provides pictures of your heart. They can help your clinician find out what kind of plaques you have. And these tests determine whether you need medication or just lifestyle changes, or you're a serious risk for a heart attack. And why is it done? Well, you may have it ordered now, and you may want to ask your clinician during a physical, can I have one of these done? It's an understanding of your risk of heart disease. Like I said, it is an X-ray, so there is a little bit of radiation. It's a CAT scan. It shows multiple images of plaque deposits in the blood vessels. And the imaging test provides an early look at levels of plaque. So it's great if you have more than one so you can compare over the years. So when is a heart scan actually used? Well, it helps guide treatment if you are low to moderate risk, like me, of heart disease. It may help motivate people at moderate risk to make important lifestyle changes. And when is the heart scan not used? Well, there's exposure to radiation. And the American College of Cardiology and American Heart Association says a heart scan may not be recommended for the following people: men who are under 40, women under 50, because it's unlikely to show that the calcium that's detected at those young ages. People who have a very low risk because detectable calcium is highly unlikely. People already have a high risk, especially heavy smokers, those with diabetes or very high cholesterol, because the heart scan likely will not provide any additional information to guide you. People with symptoms of a diagnosis of people with symptoms or a diagnosis of coronary artery disease, because the procedure won't help better understand the disease progression, and people who already had an abnormal coronary calcium heart scan. So that's really important to know and to be watching that. Well, like I said, there is some X-ray exposure. Walking into a heart scans clinic, they are not ordered by a clinician. So how are you going to know what to do with this information? And the heart scan may not be covered by insurance. It cost me $100. It wasn't covered, but for $100, it was worth it to me, because I'll tell you what happened. So you're asked to not drink coffee or smoke for 4 hours before the test. You show up and put on a medical gown and remove all your jewelry around your neck or near your chest. And the process of the scan begins where the technician puts on electrodes. They're used like for EKG. You're lying on a table, and there is a tube-like scanner, like an MRI kind of thing. It's open tube. Your head is outside of the scanner. The room is usually cool, and you're lying on this table. They leave the room and they talk to you from a speaker. They want to make sure that your heart rate is kind of low when you're getting this done. So they'll check your blood pressure and your heart rate to make sure that they can see everything. Because if you speed it up because you're nervous, they won't be able to see every action. So they're going to maybe give you medication to reduce your anxiety. Process takes about 15 minutes. And when you get the result, it's called a Agatston score. Okay. And the scoring is really interesting. So I'm going to have you come back to me. Well, first of all, I could show you, this is the major aorta here. They're looking for calcification throughout these major arteries here. And this is what a scan might look like, and see what calcifications exist. So when you're getting scored, and this is actually what my results look like. It was just like a test that showed, looked like this. It showed all those 5 major arteries I told you about, and it comes up with a score at the end. A score of 0 means no calcium is seen in the heart, and there's no or very little risk of developing a heart attack in the future. And if the calcium is present, the higher the score, the higher your risk. So that would make sense. A score of 100 to 300 means moderate plaque deposits. A score of 300 or greater is severe disease and heart attack risk is high. So it's kind of important. I had it done, and what it does is each of the major arteries had a score. So 3 of my major arteries had 0. One of them had 4 and one of them had 3. And they said the score was 8. I mean, I added up and it's really 7. But anything between 1 and 10 means I have minimal risk of heart disease or heart attack. So for me, that helped my cardiologist say, you know what, you don't have to go up on that crest score. And maybe we can even cut it back or take you off of it. Love that. So for $100, I was able to not have to go on more medication, which I certainly did not want to do. And, you know, it kind of guides your clinician to no change in the treatment, or maybe a different medication is needed, or maybe you just need to add more diet and exercise, have new weight loss goals. It's just really, really cool to have that. So I know we went over a lot of stuff. Take your time, go through these slides again carefully, look at your blood work, be proactive. You can change a lot of the things that are going on in your lifetime. And this test was really cool. Ask it during your regular physical if you are a good candidate to have this test done to help determine whether or not you can have your cholesterol maintained as it is without increasing any medications or changes. All right, so from Nancy, the nurse practitioner at Caregiver Success, please follow me on my channel. I got lots of videos out there. I do have a book for you that I wrote called Caregiver Success. It's on www.caregiversuccess.com. You can buy it there or on Amazon. You know, mom moves in, but she doesn't come with instructions. And we're all getting older and we got to know how to take care of ourselves. So here you go. Until the next video from Nancy, the NP. Take care, everyone. Bye.